Hello, and welcome to today's webinar, the Top 7 ED Workflow Optimizers. Today's session will discuss some fast facts on the current state of the ED and provide background on the research used to compile this list before counting down the top 7 ways to optimize workflow in the ED. My name is Ann Beatty. I'm T-Systems Senior Marketing Coordinator, and in just a moment we'll be joined by our presenter. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question. We will gather these questions and address as many as time permits at the end of the session. If we don't get to your question, we will follow up with you with an email one-on-one. We will have a recorded version of the session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording to all attendees after the event. And now, leading our discussion today is Janie Schumaker, Manager of the Center for Performance Excellence at T-Systems. Janie is also a practicing nurse at Lawrence Memorial Hospital in Kansas, the Chair of the Quality Initiatives Task Force for EDPMA, and sits on the Board of Directors for the Board Certification for Emergency Nursing. With 20 years of healthcare experience, Janie's diverse background has made her an expert in organizational change management. And now to kick off our presentation, I'm going to turn it over to Janie.
Well, thank you, Ann, and welcome to all of you, and thank you so much for taking time out of your busy schedules today, right here 5 days away from Christmas. We really appreciate your time, and it's our pleasure to be able to deliver some of these good work tools to you today. So our agenda, and this is just a bite-sized half hour, maybe some of you are grabbing your lunch while you listen, and so I'm going to be very mindful and stick to our agreed time. But what we're going to talk about, I want to introduce to you the Center for Performance Excellence that T-Systems has. I want to make sure everybody knows about that. I do want to take a look at some fast facts regarding the current state of the union in emergency medicine, and then we're going to look at these 7 workflow optimizers that we really like, that we've picked out from across the country, that we feel like work really well and many times can be fairly quick wins. And then we'll also look at some national benchmarks, the ones we've pulled. Just to let you know a little bit about the Center for Performance Excellence is a fairly new department that T-Systems has. It's just a little over a year old. And this team is comprised of nurses and physicians and coding and billing experts. We visit emergency departments across the country and do analysis on workflow, quality issues, risk management issues, and of course coding and billing practices. So we've really been able to take a look across the United States and see what works well. We see what doesn't work well, and so that's a lot of what's got into bringing this to you today. The other thing that I would tell you is that all the clinical people on this team continue to work in the hospital setting. So we continue to practice clinically, and so we are able to put these things into practice and see how they really work in the real world versus just being able to talk about them. We've collected many of these best practices from our clients, and then we've also collected some from people who aren't our clients, but we feel like we learn and we share from everybody we encounter, and that's a really wonderful thing to be able to do in healthcare. So anyway, that's kind of how we've gotten to the 7 workflow optimizers that we're going to share with you today. Just some fast facts. Right now in the United States, there's about 123.8 million emergency department visits annually. So that's what a lot of us spend our time taking care of, all those visits. That's a lot of visits. There's the number of injury-related visits in those 123 million are 42.4, so 42.4 million are injury-related, which brings us to 41.4 visits per 100 people. The percent of patients seen in fewer than 15 minutes is actually 18%. The percentage of visits resulting in hospital admissions averaging across the United States is about 13%. And that's right in line with what we see across the United States. Some hospitals may be just a touch under that. Others may be a little bit over that. We usually don't see anything above 20 or 22%. So 13% is your average. And then percent of visits resulting in transfers to a different hospital is an average of 1.7%. ED visits increased by 23.1% between 1997 and 2007. That's double what we'd expect to see given the current growth of our population. And I'm sure many of you out there can relate. You're saying, yeah, I think those 23.1% all came to my emergency department. The greatest rise in visits was people 18 to 64. And that makes sense because we hear about our younger population choosing not to get insurance sometimes because they think, oh, you know, I'm healthy, I don't need insurance, and then they may end up in the emergency department because it's very difficult to get into primary care. The number of available emergency departments actually decreased by 5% during this time period. So we've got visits going up by 23%, but our available emergency departments decreasing by 5%. The median wait time to see a physician during this time period rose from 22 to 33 minutes, not surprising. And with 40 million newly insured patients entering the Medicaid system, ED visits are expected to continue to rise. So it'll be interesting to see as we look ahead how that percentage changes. So now let's take a look at what we can do, because we obviously have got to be as efficient as we can, and our throughputs have got to be doing very good. So this is a picture of a stream, so we want everything to be streamlined. So let's take a look at some things that we've come across that we think are really helpful. And I always get the question, well, which one of these is most important? Which one of these should I do first? It's very difficult to answer that question because everybody's, while the emergency department setting is very similar across the United States, what's going to work well in one place may not be the answer for you. Your answer may be different. So it's difficult to say what the best thing for you is, but all 7 of these are good, and certainly by choosing to work on one of these, you would not be going wrong. So number 7 is the quick registration process. And some of you may say, gosh, we've had quick registration forever. That's old news. And the reason I put it here is because it's amazing. There are still many, many emergency departments out there that don't have quick registration. So we put our patient in and we start taking care of them, and you know, sometime we get them entered into the system and we get our labels and we can start processing laboratory and radiology orders. So quick registration process, we like it because it allows for immediate entry of patient demographics into the system, and you can immediately begin to order things and get things cooking for that patient. So it facilitates that patient care to happen more quickly than if we don't have a quick registration process. The best practice we like to see is that registration be responsible for registering patients. And oftentimes we still see where nurses are doing this. And we like for the registration, and maybe you call it something else, but registration staff, business office staff, patient access, whatever you're calling that position or that role, we really like to see that role facilitate that piece of work. And for a couple of reasons. Number one, we like the nurse to be freed up to take care of the patient. And number two, we find out that the registration staff cause fewer errors, or they may have a little more diligence in entering the information exactly correctly, and we don't start to get into duplications of our master patient index and things like that. And certainly nurses are not bad people and they're not prone to errors, but registration, it's a proven fact that registration has fewer errors when they are the ones entering and doing this function. Nurses are geared toward taking care of the patient's symptoms, complaints, saving their life. Registration is more geared toward entering the information into the system. So we like to see registration for this. And then barriers to this that we've encountered, sometimes people say, well, gee, my HIS system, and when I say HIS system, that's whatever system you're using to put your patient information into. Maybe it's, maybe it's Meditech, maybe it's CPSI, maybe it's HMS. So it's whatever Siemens, whatever your HIS system is, people sometimes say, well, gee, that we don't have the capability in our HIS to do that. And so I would challenge you to go back and double check that, because often you'll find out the capability is there, it's just not being utilized. And then the second thing is we see a lot of resistance to this. So if we've never had a quick registration process in our emergency department before, there may be some resistance to change, and people say, well, gee, we've always done it this way. Why do we need quick registration? So it's a mindset. So those are two barriers that we tend to see. But quick registration can definitely facilitate patient care and get things happening more quickly for the patient, help you track your throughput times more efficiently and effectively. So we like the quick registration process. Number 6 is the immediate bedding, or the pull-to-full. We're starting to see it called pull-to-full. Immediate bedding terminology has been around for a while. We love immediate bedding because it immediately improves patient safety. We don't have patients standing in our foyer or our entryway or sitting in our waiting room waiting to see the triage nurse. All of the emergency department patients that walk into us, of course, are unknown. We don't know what's wrong with you when you come, so the quicker we can get you in a room and get you assessed, the safer that makes our care. So it immediately improves patient safety, and it really helps with those early throughput times, too. Your door-to-room can be immediate. It can be less than a minute, and you can just do your triage assessment and your primary assessments all right there in the room, and oftentimes it's just a matter of figuring out, is the triage nurse going to be the one that brings them back and does a quick assessment? Oftentimes that works. Or do we just put them in a room and let the nurse who's going to be their nurse throughout the stay do the whole thing? And that helps a lot with continuity. The patient then only has to tell their story one time to one nurse. So that's a nice piece to it. So that's really going to help you with patient satisfaction. I only had to tell my story one time, and gee, look, you guys really, you really care about my treatment. I got to a room right away. And we can get our care started right away. And I've got a little example over here of a nurse-driven protocol. So as I pull people back to a room, I can go ahead and get some orders started. In this case, if we have an abdominal pain, I can go ahead and collect that urine sample or whatever. So I've just got a real win here. Now I've got the patient immediately in a room. I've got care started, and I can just do my triage and assessment all at the same time. Barriers we see to this, though, and this is a real thing, is that rooms do get full. And so once rooms are full, then what do? You can't immediate bed if all your rooms are full. But we have a couple, the good news is we have a couple of optimizers later on in the presentation that are going to help us with that problem. The other thing is resources. Do I have enough resources to be able to pull this off? And sometimes it's just a matter of trial and error. Let's try to work this 2 or 3 ways and see what works best with the resources we have. And then triage also has to undergo a paradigm shift. And again, it's a mindset issue. So triage is not necessarily a place, it's a process. And really the true meaning of triage is to make sure I get you to the right place at the right time to the right caregiver. It's not really about filling out all the paperwork or making all the clicks in the computer. It's more about what do you need right this second, and how full are you to wait. So it's a process, not a place. So we have to think about triage differently in order to pull immediate bedding off. Number 5, patient care areas by acuity. So we like to keep low acuity patients out of the main ED. So if you don't need to lay down and you can sit in a chair, then perhaps we'll sit you in a chair. Why keep your lower acuity patients segmented, put them in their own area. Maybe that's an area right off triage, or you can get real creative. And again, this definitely goes back to mindset. This is more of a process than a place as well. But we know that segregating lower acuity patients and treating them quickly gets them out of your emergency department, and it will decrease your length of stay for that population. And the other thing is that your lower acuity patients are the ones that are filling out the patient satisfaction survey for the emergency department specifically. The patients that are acute, that lay in your ER a little bit longer, that take a little bit longer to work up and get admitted, they get a survey too, but theirs gets jumbled up with how the admission went and all of that. These lower acuity people, you want to get them happy because they're the ones that are going to really hit the nail on the head about how the ER care was. So we like to segment them and treat and street them faster. That also helps the high acuity patient get the focus and attention they require because people aren't bogged down with, having to get some things going for some of these other minor things. They can really focus their attention on the sicker patients. And we can utilize a mix of caregivers. Maybe you can use a tech. Maybe you can use some LPNs or LVNs. There's all kinds of creative things you can do with your lower acuity patients. Some of the barriers are space. Some of us are just out of space. But you know what? In one of my past ERs, we had chairs in a hall that were partitioned with some privacy screens. And we did that while we were under construction. We offered people the option for a bed since that was sort of construction zone. And, no one took us up on it. Everybody said, nope, put me in the chair. I'm going to get seen faster. And, boy, we were able to shave a good hour off our 4s and 5s and some of our 3s. It was wonderful. Again, this could be a resource issue with barriers. What resources do I have? Maybe I need to ask for another resource. But think about this. If you can turn your beds faster and see more volume, the resource pays for itself. And then, once again, we have a mindset. You have to have the ability to see this change as a good thing. And not always thinking about, sometimes we run into, well, gee, I don't know if we can do that. I don't know who's going to be receptive to that. So mindset, once again, with this. Number 4, we really like team assessments. And when we say team assessments, so that's the provider. So it's the physician or it's the nurse practitioner or the physician's assistant and the nurse. They're going to go in and see the patient together and get the story from the patient. And this is really fabulous, too, if you've got immediate bedding. And the nurse that's going to be assigned to the patient and the provider can come in together right out of the gate. So the patient gets to tell their story fewer times. We're going to use each other's strengths to ask questions. So something the physician forgot to ask, I may remember to ask. And something the physician asks, I may not have thought to ask. So we're both going to be able to benefit from each other's assessment skills. And it conveys a real sense of patient-centeredness and teamwork to the patient. So we love team assessments. The barriers to these are, of course, as you know, sometimes it's not always possible for everybody to get in the room at the same time. But even if you can do this half the time, it's very worth it. And it's very patient-centered, and it's a great patient satisfaction booster. And again, like I said, team assessments, we're building off each other's strengths and asking questions together. We're going to get a better story from the patient. I would say, though, that in addition to the availability of caregivers and the time this takes, once again, mindset can sometimes be a problem. Sometimes people are set in their ways, and they'd rather see what the nurse's notes say before they go in, or some of those kinds of things. So some of these things do come with some barriers, and we understand that. But, again, this is a very good one to work on if your environment lends itself to it. Number 3, results waiting area is a terrific thing to be able to do. We like it because it provides flexibility to your emergency department. So what this is I put my patient who is waiting for the x-ray result or waiting for the last half of the bag of fluids to go in. They're a stable patient. They just needed some fluids. Or we're waiting on a urinalysis test to come back to confirm our UTI. They don't really need anything beyond that, so we put them in what we call a results waiting area, and we can make this comfortable with some recliners. Maybe you've got some extra stretchers, or you can find some somewhere. And what that does is it moves them out of your treatment space so you can bring the next patient in. And then once this patient's results are back, they can be discharged right from the results waiting area. You can staff your results waiting area with a mixture of providers or caregivers that you think is appropriate. It is helpful to have some guidelines about who can go to results waiting. Certainly you wouldn't want to put anybody in there who's really sick. It's not a place usually for admissions to go unless they're really being admitted for something very minor, which doesn't happen too often in this day and age. But this thing done well can really provide some great flexibility and allow you to turn your beds more quickly. And it keeps things moving for the patient, too. You can say, hey, we're just about to let you go. We just need to get this result. Shouldn't be more than 20 minutes. We're going to put you in this nice comfy chair. Here's a TV. So we love the results waiting area. Again, some of the barriers might be space. Sometimes space is an issue. Where are we going to put this area? How many people can we fit in it? But, even if you can put 2 or 3 people in this area, that's 2 or 3 new beds that you just gained where you can bring your next sick patient in and get them started. Again, this goes along with mindset. This is a big change sometimes for the ER, so we have to talk this through and help people understand why this is a good thing. Resources can be a barrier. Maybe I don't have anybody to staff my results waiting area, but once again, if you can show that you're going to be able to see 5 more patients today because you had this, or 5 or 10 more patients today because you had this results waiting area, that's more potential revenue and downstream revenue for the hospital. So, could we staff that with a tech, or could we staff that with an LPN or an LVN or maybe even an RN, because somebody does need to give the discharge instructions. So perhaps we could argue that since I'm going to be able to turn more beds and see more patients in a timely manner, this would be a good resource for me to have. So the resources and financial considerations for this results waiting area can sometimes be a barrier, but we see a lot of places using results waiting, and they're very successful with it, and they're able to keep moving, and they hardly have anybody. People that do this well hardly have anyone at all in their waiting room. It's amazing. This thing works really, really nicely. Our second one, number 2, is visual cues for workflow and processes. So what this means is if you're electronic, you're really using that status board to watch for new orders. You're really watching for when results are back, and you're using those visual cues to manage workflow. If you're not electronic, there are still very, very many creative things you can do to make sure the nurse knows when there's new orders, to make sure we know when results are back. We really like to use visual cues so people don't have to guess when things need to be done or remember to look for them, because the human brain just doesn't work very well trying to remember, gee, I need to look for bed 5's labs. They're probably back by now. So visual cues are going to save us time in our throughput. They help us with transparency, so when somebody's ready to be discharged and their nurse is tied up, some other nurse can go and make that discharge. So it's also a very good communication tool. Barriers to those, once again, can be mindset. I don't want to use the status board. That's not, I don't want to be bothered with that. We hear some of that grumbling, but it's a very easy argument to make for visual cues. Financial considerations, maybe sometimes people aren't quite ready in a position to go electronic yet, so let's get creative with our grease board or what we do have in our department and set some of these visual cues up. And, then also strategy. Sometimes strategy is a barrier. Maybe you're in a hospital system where the corporate strategy is that we're going to go with X product in 2 years, and so that leaves me for 2 years wondering what to do. Don't wait 2 years. Go ahead and get creative and get your visual cues in place now. It's going to really help your workflow. And then number 1, bed ahead and bridge orders. So on the back end, as people are being admitted, we've got to be able to move those patients out of the department. So we really like the concept of the inpatient units always keeping a bed ahead for the emergency department. Historically, by looking at your numbers every day, how many people you're going to admit, you can kind of plot and plan how many beds you need every day. But we need to really keep a bed ahead for our ER patients so that we can keep patient flow moving. The other piece to this is the bridge order. So the emergency physician, we like to see them just be able to write 3 or 4 or 5 orders, enough to get that patient started. It's called a bridge order, and be able to get that patient on out of the emergency department. If we've got a consultant or a hospitalist that wants to see the patient and write orders, that's good, but if it's impeding your flow, I would argue that we would want to have them do that in the patient's room upstairs so that we can go ahead and turn our beds over and keep our volume moving, because we've got 123 million patients coming to the ER every year. We know that's going to grow. We've got to keep our beds free. So, if we need to go ahead and get those bridge orders, let's let our emergency physicians do that. Most of them are agreeable to that. Let's have our consultants and hospitalists, unless they can get down there and really get those orders written lickety-split as fast as you can do a bridge order, then let's have them see those patients in the inpatient unit and keep our beds free. Also, this is going to improve patient safety because the longer we have inpatients laying in the emergency department, most of the time we expect our emergency department nurses to take care of those patients plus whatever's coming in the door. So if you've got people that are in the emergency department that should be on the inpatient side, are they really going to get the full attention they need as the emergency nurse is trying to take care of the new patient? Or is the new patient going to get seen timely enough because we're still trying to take care of the patient that should be admitted? So it's a patient safety issue. And we want to be able to free up our ER caregivers so that they can keep seeing the new patients as they come in the door. So barriers to this, of course, again, we have mindset. Or are we resistant to this? Do we have people that are resistant in the organization to the bridge orders? Do the hospitalists or consultants not want to see their patients in the inpatient units? We've heard all of these things, but the argument for good patient flow oftentimes can win out over those arguments. There has to be a commitment, an organizational commitment to ED patient flow, and sometimes that can be a barrier. And then, of course, resources and space. Sometimes patient populations in a given area are growing so fast that hospitals simply run out of beds. So we've certainly seen that happen as well. Okay, so you probably noticed during all 7 of these that the common theme in our barriers was mindset. And I think we see mindset being a huge factor across the country, more so than any of our resources or financial considerations. So this is kind of a fun thing. Change is good, you go first. So I know that this is something we struggle with. And what I recommend to offset this is we get our facts together and we say, here's why this is going to be good for us to do. And you always put the patient first, as you all know. You put the patient in the center of this, and we talk around why the patient in the center of this, why this change is going to be good. And it gets harder and harder for people to argue with us. But definitely as we go across the country, resistance to change and how we think about things is a huge factor in helping us with really good processes in our emergency department. So I would imagine some of you struggle some with that. Now, a few benchmarks just to kind of say, gosh, how are we doing? And when we say benchmark, this doesn't mean this is where I ought to be. This just means this is the national average. These are the ones that are published. So there's a left without being seen rate that's 2%. That's the national average. If you're below 2%, then that's good. Of course, you don't really want anybody to leave without being seen from your emergency department. Those patients are already in your door. That's about a $500 loss every time one of them walks out. And they were already in the door, so that's business that you lost, and somebody could go down the street and have themselves a new hospital. So we don't want that. Plus, it's a patient safety issue. Every once in a while, we read in the newspaper where somebody left and, fell out in the street and that kind of thing. So we really like to see this way down below 2% as a best practice. This average length of stay across the country is 4 hours and 7 minutes. That's all comers in that 123 million, sort of an average of all those. And this was published by Janie. So do we think that 4 hours and 7 minutes is a good throughput? It depends on whether the patient's being discharged or admitted, but we believe this number is too high. So we would encourage you to shoot for a lower number than this, particularly on those patients that are treated and released. Door-to-provider time, the average across the country right now is 56 minutes. I think the gold standards become definitely 30 minutes or less, so we would encourage you to shoot for that. And then this new CMS measure that's been out for a couple of years now that's being publicly reported, the door-to-EKG, of course, you definitely want to be under 10 minutes. And I know where I work, we don't even register the patient until we have the EKG, so our number looks really great. So there are some things you can do to kind of help with some of these things. But these are just some benchmarks that we've found in the literature that we thought we'd give to you, and you can kind of say, wow, how do I stack up compared to some of this? So in summary, I would just like to tell you I'm right at my 30 minutes. My team and I believe that the ER is the front door to the hospital, and it's a vehicle for so much downstream business for the organization. So we could argue all day, and we'd be happy to help you argue, that your emergency department needs to run efficiently and smoothly and make a very good impression on your patients and their families that are coming for care. So an efficient patient-centered workflow and processes that eliminate and minimize the non-value added patient experiences are critical. So things that patients don't see as value add, you really want to try to minimize that. And these 7 things we've given you today really help do that. So, you know, sitting in a triage booth for 5 or 10 or 15 minutes versus going straight to a bed, in the patient's mind, going right to the bed is definitely more valuable than sitting in the triage box. And then providing processes that make a chaotic environment easier for your staff, such as a user-friendly documentation system with built-in regulatory and documentation prompts, visual cues, things like that. All of that just pays dividends. So you want to get things and tools for your staff to use that are easier for them and not harder for sure. So with that, Ann, I'm going to turn it back to you and see if we have any questions, because I am right at my 30-minute mark, and I want to be respectful of that.
Absolutely. Thank you, Janie. It does look like we have maybe 1 or 2 questions. Like I mentioned, if you want to go ahead and type your question into the Q&A or chat, we will, try to answer a couple here really quickly, and if not, we'll definitely, send you an email and follow up with you later. One question we had, Janie, was which one of these would you recommend is making the biggest difference in terms of patient satisfaction?
I think in terms of patient satisfaction, I'm going to go with the immediate bedding probably as my number 1, because you're taking me right to a bed. You're not making me stop anywhere. I'm going straight to the bed. So I guess I would probably pick that one as top for patient satisfaction, probably followed by those team assessments.
Okay, great. And it actually looks like that is our only question for now, and like you said, we're right at our 30-minute mark. So we are going to go ahead and sign off, but I will, as I mentioned, I'll be sending a follow-up email with the recording later today, and feel free to respond to that email if you think of any questions in the meantime, and we'd be happy to answer them. So that will conclude today's webinar, and again, thank you so much for attending. Bye.